here,
Yes.
Director Sri Netralaya, Vice President of All India Ophthalmic Society. So Dr. Partha is going to operate an IPCL patient. The details are as follows. His patient's name is Rahul. His left eye is going to be operated. He's got a spherical error of minus 9.5 with cylinder 2. His PACI is 512 and his white to white, both digital and optical, is 11.5. So we are planning to implant an IPCL
राहुल सीधा देखना
13.
सीधा देखो बेटा
Sure.
सीधा लाइट थोड़ा
Can
bright
we have
करो।
the microscope view? Yes.
Yeah.
Yes. Yes. Perfect.
So this is the model of the IPCL which we are going to implant. That is IPCL 13.
राहुल इसको ऐसे करके रखो। So first we would like to show you how to load an IPCL cartridge देना भैया। So the IPCL, the cartridge actually needs to be soaked in BSS at least for 3 to 4 minutes before we put in the lens in the cartridge. And that's an important step. The cartridge should contain enough of viscoelastic and enough of BSS so that there's a good and smooth flow of the IPCL once it goes into the eye. So it's important that these things are adhered to, and none of the steps should actually be bypassed.
Yes, sir.
Yeah. Rahul, comfortable ho beta? Okay. So if you can see, can you put some visco on the cornea, please? Sundar? So Sundar is assisting me here at Drishti, and an excellent setup. You just need to see the excellence of not only the setup, but also of the persons who are here. And it's an excellent way that they are assisting, thanks to the whole team, and of course to Gaurav and Saurav who lead this team. So now we take the IPCL. The IPCL, the benefit of an IPCL is it comes in a very wide range. IPCL डालो मेरे को दो, cartridge दो, cartridge. IPCL का vial दो. Open the IPCL, please.
So can we see the loading of the IPCL
Yeah,
first?
I'm just going to show you, Namrata. So they are just opening it, and IPCL, they have the benefit that they give 2 IPCLs so that if there is a damage or if there is a inadvertent fall, you know, you always have a backup. So that's another very big benefit that we have here. So it comes housed in BSS, and visco de do please. Cornea pe. So here is the IPCL, and the positioning of the IPCL is very, very important. So there is a notch, and the hole has to be the leading left. So we have to position it in such a way that it goes into the cartridge with the proper positioning. So now, can you see the cartridge dena beta? Can you see the IPCL?
The focus.
Ji, I'll just focus it for you. Now, there are 2 holes on the optic. They have to be superior. And there's a hole in the leading left. So that is supposed to be there, and a notch in the leading left. So we just place it in here.
So it's
And in the,
so if we could make it slightly more clearer, it is slightly blurry for the audience. Yeah.
abhi theek hai? Is it better now?
Yeah. थोड़ा और
Better,
ऊपर
but
कर
can be even better.
और थोड़ा ऊपर. माइक्रोस्कोप नहीं दिख रहा है.
ये ठीक है?
नहीं. Somewhere on top.
So it goes in, and in the cartridge,
Not focused.
not focused.
No,
Yeah,
no.
it can be better, sir. It can be, if you could focus it more, maybe.
Not focused. थोड़ा और ऊपर करके दिखा दो. नहीं नीचे करो.
Yeah.
नीचे करो.
Yeah.
हाँ. हाँ.
Yeah, now it is better.
Right, better.
Better.
Okay.
Yeah.
So you just clip it in,
Right. And lock it.
and yes, it is nicely locked now. Cartridge holder. So it just goes in very, very comfortably, and this is the most important part
Yeah.
of the loading of any phakic eye.
Now be better now, yeah.
So the loading is 90% of the job to be done.
Yeah, as we have seen very beautifully, the loading is the most important part, and that is one of the advantages of the
Yeah.
IPCL, because the loading is easy and very
And what we
intuitive
need
for
to do
cataract
is
surgeons.
now to gradually place it in the nozzle, near the nozzle, and see that there is a very, very gradual and a smooth flow. And this has to be placed again in the BSS. So now we go back to the eye and magnify a little. Side ports then bhaiya.
Focus.
We have the use of the variant. Variant to hai na?
हाँ वेरिएंट लगा
जी.
ऑन कर दो वेरिएंट
Side ports है ना? ये देना. Okay. Pulsars. We'll make the side ports. हाँ, variant थोड़ी देर में. राहुल comfortable हो बेटा? Okay. Pinokin है?
Yeah, sir, it can be focused better, I believe. It is coming blurrier here. We can
Actually, it's
probably.
very well focused for me.
Yeah,
Oh,
but in the,
okay.
now it is better. Now it
Is it better? No, it is not focused for me. Anyway,
Oh,
we'll,
okay. So you have to be comfortable, of course.
yeah. So we have these two ports now, and I'll take phenocaine or an anesthetic, but Rahul is very, very comfortable, and so Rahul, थोड़ा सा दबाव पड़ेगा बेटा. जब दबाव पड़ेगा, तो don't move. हाँ?
Yes.
Are you comfortable तो?
डाला हुआ है ना बेसिस को
इसके बाद मिथाइल सेल्यूलोज देंगे, एयर फ्री करके.
सुंदर इंजेक्टर बीएसएस में डुबा के रख लेंस को हाँ बीएसएस में डुबा के रख
Now मुझे विस्को देंगे, please.
So you have used an intracameral anesthetic.
Yeah, we put in a little bit of phenocaine intracameral. Now the next thing is cornea को देंगे. Cornea, please. So the next thing is an important part again. So placing in the viscoelastic, and these streams of the viscoelastic that you see, they should gradually coalesce from one to the other, and there should not be an overfill or an underfill. So now that's a little on the tensed side. Now main port, please. So the main port is a 2.8 port. A little bit, I'll just widen it a little, though it does not need visco, please.
So what is the size of this incision?
It's a 2.8. I did extend it a little bit just to be as smooth as possible while we inject it. I'm tapping this just to see that we are nicely filled. Now placing the ICL.
Sir, are you in focus completely there?
I am in focus. Are you in focus or not?
Sir, it is blurrier here. It's not in focus.
अच्छा मैं देखता हूँ.
Okay.
नहीं out of focus
I think can we readjust? Okay, you continue
keep-
to do. It's okay, Partha, you continue to do.
Is it
it is
okay?
not focus at all
It is not focus.
no nothing
I think there is a discrepancy between, sir, your focus and our focus somehow.
nothing is there
Yeah.
focus for you
It is focused for me
so
actually.
there is you need to adjust
अभी ठीक है?
नहीं
No, sir.
अच्छा, let us gradually carry on.
between what
Yeah.
we see here and what is focused there नहीं वही मैं बोल रहा हूँ डिले चल रहा है
So now we
Delay हो रहा है।
place in the
ये वहाँ दिख
ICL.
रहा है ये डिले हो रहा है नहीं ये फोकस्ड है हाँ ये वहाँ भी फोकस नहीं दिख रहा मतलब ऑडियंस को ये ऐसे दिख रहा है
So as one can see, sir, is very gently and very, very slowly
both the cases were like that
planting
only.
it.
both the cases are हाँ बट डिले हो रहा है
So these holes, are we focused?
No,
No,
nothing,
not
nothing
focused.
can be
अच्छा, अच्छा.
Wortman, can you see anything
We can
Mic
see, but I think we
Abhi
need
dekho.
Now
better
focus.
focusing. No, we need better focusing.
अभी
Mic.
अभी देखो.
It's blurred for us.
Okay, so we are focusing it, just let us know when it is focused.
Can you just again adjust the microscope a little bit and then continue?
एक मिनट रुक जाओ मैं बताऊँ क्या हो रहा
Yeah, थोड़ा ऊपर. हाँ. Now is it focused?
Yeah, it is good now.
Yeah, now it is.
Much better.
आपको?
है
नहीं, वो delay हो जाएगा.
focus at all.
उनको नहीं दिख रहा वहाँ पे.
And how good is focus for the surgeon?
Is this better? Is it better now? अच्छा अभी ठीक कर लेते हैं. See, I'm going to do it under very low magnification so that both of us are focused as much as possible. ठीक है? Are we ready now? Is it better, Vardhaman?
I think you continue, Dr. Partha. Just continue.
Yeah. देखो अभी focus है नहीं है?
Sir, you have to be comfortable, so I think you can please proceed.
No.
We are able to
Vardhan,
see.
you tell us when it is focused.
It is blurry, Dr. Amit.
Yeah.
It is-
So he is focusing it.
It's becoming
It's become more blurred than before.
नीचे करना पड़ेगा.
अभी देखो.
You have to move in the opposite direction. It is now getting better.
हाँ, it is better. और थोड़ा सा नीचे. बस. This is better?
Yeah, this is the best that I think we've seen up till now.
चलो Cornea. I'll just show you the markers. So can you see the holes in the optics here?
Can we remove this overlay? I think this is coming from very on. Can we remove this because we can't?
Yeah.
Yes, now it is better. You can
So-
increase the magnification now. Partho, it's focused also well.
अच्छा ठीक है. I'm not focused, but anyway, let me just try and tell you. So these are the two holes on the optics which have to be superior, which they are, and there's a leading notch here.
Right.
So the leading left should have that notch, and it's there. So the vault is in proper shape now, and now I'll have to focus it for myself, I think. So please allow me that.
Yeah, please, sir.
So here we are. Now tucking in is a very important cornea, please. हाँ जी. Rahul, comfortable हो बेटा? Yes. Okay, good. So we just go over and go to the haptic and just tuck it in very gently. So the tucking in is important. The negotiation to the haptic is important.
Yeah.
And similarly, going in through the,
See anything?
I know, but मुझको देखना ही पड़ेगा.
हाँ, सही बात.
So I'm sorry, I think you cannot see, but I'll have to see it as I'm tucking it.
Yeah, yeah. No problem, sir. I think we are.
So all nicely tucked. Now I'm going to show you. Is it? Are you able to see now?
Yes, yes, much better. So we
Okay.
have just seen
Cornea,
the way
cornea,
the
cornea do better.
foot plates of this IPCL were tucked under the iris very beautifully by Dr. Partha, sir.
So now the next part is orientation to 180 degrees, which is another great benefit. Now Varion de do please.
Variant on करो.
Now this is very important because you do not have to orient it to the axis of the cylinder per se, but you just have to orient it to 180 degrees. And that's where they actually place the cylinder in such a way so that it is well oriented. Can I have the axis please? Varion axis.
Variant on है.
Varion on hai, axis डालो please.
Axis डाल front.
0180 axis overlay, please.
180. 180 please.
So as Dr. Partha sir has just said, one of the beauty of this particular phakic lens is that you don't have to rotate it, and that is why it also gives more consistent vault, because your rotation is going to change the vault a bit.
180. 180. The other benefit is we have the central hole, which is a little different from the central hole of the ICL. So it is 380 and 420. Now 420 is in the inner part. You have to. थोड़ा बड़ा है. Can you give me the side port, please, Max?
Okay.
So I believe this kind of conical architecture of the hole reduces the amount of glare and halos for the patients.
Absolutely, Vardhaman. That's a big benefit, and that's an innovation that they have come up with. So it's something that is very useful. And the best is the sizings. The sizings come in 0.25 differences. ये वाला So we can actually move this irrigation port a little onto the central flow, but only for a very short while, and take out all the viscoelastic. We have used, we are here. आ गया है. 0180, you can see it's 0180, nicely focused, and I can see that the vault is nice and good already.
Right.
So even eye assessment can be done for this.
अब बाजू में आ जाओ.
Cornea, please. Cornea down.
ये भी नहीं चाहिए.
Yeah. So it's beautifully perfect in position.
हाँ, मेरे लिए एकदम बिल्कुल focus. Yeah, very well focused.
Yeah, it's more submitted, more it.
So,
Better.
yeah, is it better, Vardhaman, the focus?
Yes, yes, sir. It is better than before.
No, we are trying to change the focus over here, so
Right.
let us know when it is the best.
It can be better.
It can be better?
Can be better. Do you have a display there also, Dr. Amit? I mean,
Yeah, we have a display here. We are checking in our display also.
Correct.
So let us know when it is best there. We are trying to adjust
Here
it.
it is
also.
okay.
Now it is quite all right.
Okay. Done. So this is the view you will get in all the cases now.
So, thank you very much.
Thank you, sir. Thank you so much for a beautiful demonstration of this
Here, this is the
innovative
superior.
phakic lens. Yes,
And
perfect.
we will put in a little bit of moxifloxacin, which we use for all our cases.
Right, sir.
And that's the end of the surgery.
Thank you, sir. Thank you. Very beautiful demonstration. Thank you so much, Dr. Parth.
Cataract services at Narayan Vidyalaya, Bangalore. Today she's going to operate on an 85-year-old male who's been a known case of glaucoma since 6 years, but has a history of trauma in right eye. Initially, the AT has always been maintained. The diagnosis is right eye with early glaucoma and subluxated cataract with poor vision, and left eye pseudophakia with moderate glaucoma. Patient is on both eye Combigan with left eye additional letanoprost. The patient underwent a right eye cataract surgery and was on eye drop Travacom for the same in both eyes with additional eye drop Simbriza in the left. Left eye visual field suggestive of glaucoma progression. Initially, a trap with MMC was done, and the left eye showed good IOP control for 1 year. IOP was actually maintained for quite some time, but presently patient is on 4 anti-glaucoma drugs, which has poor compliance to medications. And today this patient has been planned for left eye stent. So we are just preparing the OT, but over to the eye stent OT with Dr. Sushma, please.
Images.
BCL बता दो. Thank you, thank you. बस हो गया, अच्छे से हो गया.
Can we have the microscope view, please?
बंद कर लीजिए.
Microscope view? No, from the from the other OR where the surgery is going on. From the other OT.
मैम अभी रेडी नहीं हुआ.
So I would request Dr. Manoj Mathur to come for the next case here. It is MIGS, sir.
Yeah. So we welcome Dr. Manoj Mathur, sir, who is the honorary treasurer of our August Society AIOS. So now we are going to have this procedure of MIGS. So Dr. Mathur, sir, do you have any experience of using MIGS in your institute? Yeah. So can you please share some insights into this till the time we get the microscope view? Yeah. Yes, sir.
We have been doing eye stent procedures as well as KDB.
Yes.
Bang we generally don't do because bang procedure, like basically the needle, it just cuts through the Schlemm's canal and the chances of getting fibrosed again are high. Whereas KDB is proper deroofing of the Schlemm's canal so that it stays longer and it has better outcome compared to bang. And eye stent procedures in mild to moderate established glaucoma cases, initial experience with us is they really do well, and we get the pressures in teens from the early 20s. So that's about it in
I think
the
you have
early
probably one of the largest series in your state, probably. I think, how many surgeries have been done with eye stent so far?
I think about 18 eye stents as of now,
Yeah.
and we are getting good results.
Wonderful, yeah. So can we have the microscope view, please? Is everything settled over there? So I think world over the MIGS is making its big waves actually around the world, especially in the Western countries.
Yeah, the thing is like MIGS is FDA approved basically for post-cataract cases. Like generally most of the places, the cataract surgeons are doing this. In frank glaucoma, open-angle glaucoma cases, it is yet to be conclusively established, but some people have done it, and response is still awaited, I must say. I cannot conclusively say that MIGS eye stent procedures can be done straight away in POAG cases. But in pseudophakics, when you're doing a cataract surgery, in the same sitting, an implantation of eye stent is known to give a good response.
So out of these 18 cases of eye stent which has been done in your institute, how many of them were
no,
pseudophakic?
like
Have you done
honestly,
anything?
like we have not done in a POAG case.
Yes, all of them
all,
have been
all
in
of them
POAG.
along with the cataract
Nice,
surgery.
yeah. So it's important in MIGS.
Varman.
Yes.
Dr. Amit here.
Yes, Dr. Amit. Yes. So we would like to know also your views about the same. And yeah.
So we are getting ready with the patient.
Perfect.
So till then, in India, eye stent is gaining popularity now. And the most common indication for any mixed procedure is it is combined with the cataract surgery. But now the indications have expanded. Even without cataract surgery, these mixed procedures can be performed. And eye stent is basically used for mild to moderate glaucoma. And phakic or pseudophakic patients, both you can try the stents. Earlier it was that only it has to be combined with cataract surgery. Now even in phakic patients, eye stents have been implanted. But in our country, still the scenario has not changed yet. But the Western world is going on implanting eye stent. So coming to mix, I mean, it all depends how comfortable a surgeon is. In India, eye stent is implanted even by cataract surgeons, but the other mixed procedures are done by only glaucoma surgeons. So basically, who can do this surgery is a big question mark, because anybody who is well versed with the intraoperative gonioscopy can do these procedures. And
So just to interrupt,
reduction of IOP.
Amit, just to interrupt, eye stent implantation, you are very right. In our center, they are done by the cataract surgeons for combined cataract and glaucoma surgery. And in our center, we've done close to 15 eye stents. I have done myself 2 eye stents. And intraop gonioscopy, if you can do like you said, it is possible to do eye stent. And because we have aqueous angiography system also, so through the aqueous angiography system, they also tried to test the patency of the eye stent intraoperatively, and it was the stents were found to be patent.
So performing an eye stent is very easy. So
yeah,
that's
so there's no, I mean, you are absolutely right that more, if you see the numbers, more cataract surgeons are perhaps doing it than glaucoma surgeons. But then that is the only surgery that cataract surgeons can do. I don't know if all cataract surgeons would be comfortable doing other form of MIGS, which the glaucoma surgeons, do so wonderfully and elegantly.
So I personally feel that there needs some skill for KDB and bang, but eye stent is very, very easy, and that's why it is gaining more popularity among the cataract surgeons. So now we are getting ready with the eye stent case. Dr. Sushma from Narayan Netralaya, she is a glaucoma specialist in Narayan Netralaya. She is going to perform this eye stent procedure. And over to you, Dr. Sushma. Would you like to brief about the patient?
Yeah, I think Dr. Amardeep, who has been kind enough to provide her patient, has briefed about the patient already. So it's a pseudophakic patient. I'm going to do eye stent on. Am I audible there?
Yes, 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 of course.
Okay, thanks so much to the AIOS for the opportunity. So I'm going to do an eye stent for a pseudophakic patient. So cataract surgery is already done. Now the most important part of eye stent is to focus on the angle and to be able to work under high magnification. So that's what I'm going to demonstrate today. Well, I'm sure all of you are familiar with the eye stent implants per se. It has three parts. One is the head and the neck and the thorax region. So the neck part goes into the Schlemm's canal. The trabecular meshwork is around the thorax and the flange part stays into the anterior chamber. And there are these channels which are in the center as well as in the head part of it, which allow the aqueous to flow. There is an injector, I'll be showing you briefly now, that has two buttons. One is to retract the sleeve and the other one is to inject the implant. Now the implants are threaded onto the trocar and this whole system is covered with a sleeve. So when you go close to the angle, you remove the sleeve and look at the trabecular meshwork, en face view, put the injector tip there and then inject the...
So can we have the microscope view, Sushma?
Yes, we can. Can you increase my chair height, please, or reduce the table height? Yeah, reduce table height, please.
First shot, second shot.
Okay, that's enough.
Second shot. 2 more shots. Total 4 shots are there. Microphone
So the patient is pseudophakic patient?
Yeah, the patient.
It's a pseudophakic patient.
Okay, I'm sorry. Right.
So the beauty with this eye stent is there are 4 shots. So quite a few times during the learning curve, when you shoot and the eye stent doesn't get implanted, you don't have to worry, you have few more shots left. And even if the eye stent gets dislodged and is in the AC, you can always pick up with the microforceps or microforceps, reload it and again inject it.
Table also down, a little more down.
I hope, Vardhman, you can see the view of the patient side.
Yeah, is it well focused for you? There?
Vardhman, can you hear?
It can be better, but can be better.
Can be better.
Okay,
Now it is better?
Okay.
Okay.
Is the illumination maximum there?
Yeah.
Hello.
No, this is something different.
Now it has become very blurry.
She's focusing it.
Sure. It is better now, significantly better.
Increase the illumination, please. Put saline on the cornea.
Now it is focused?
Is it better
Yes,
now?
yes, it's fairly well focused.
Okay.
Okay. Yes. Give me the MVR, please. So since this is a pseudophakic patient, I really don't need to make a big incision. I'm just going to create 2 side ports and use that for implantation. Well, there's a bleb here, so we have to be careful. I'm just going clear corneal here. You have to anyway go clear corneal because if you end up with bleeding, the view will get affected. There's another side port on the temporal side because I'm going to implant the stents nasally. Can I have intracameral pilocarpine, please?
445.
So I usually tend to constrict the pupil with intracameral pilocarpine there.
So Vardhman, you can see the patient is post-trap and as the indications we were discussing.
Correct.
Post-trap with 4 medications, he's an active patient, he's got an active lifestyle. So he doesn't want to inject 4 medicines. So to reduce the number of medications, we are doing this eye stent procedure. So from 4 medications, he might come down to a single or a dual medication or 1 combination drug.
Right.
These are the indications with the changing lifestyle and what the patient is required.
Right.
We can give options like that.
Perfect.
So now I have used Helon GV to form the anterior chamber. Give me visco, please. Wait.
So
Or saline on
the
the
recommended
cornea?
viscoelastic in this one is the cohesive viscoelastic.
Yeah, so we always use a cohesive viscoelastic whenever we do a mixed procedure.
Right.
So I'm going to rotate the head of the patient away 30 degrees and also rotating the microscope towards me 30 degrees. Can somebody rotate the microscope, please? No sterile switch here. Yes, yes, this one, yes.
So this arrangement is very important to have the best view
Microscope tilt,
for
please.
gonioscopy.
This one?
Nine.
Yes,
I think-
that has to be with the sterile cup so that I can use it myself, but anyway.
So
Yeah,
this,
so I need somebody's help, yes.
so
Okay.
this
Little
familiar,
more, please.
yeah,
Okay,
this familiarity with intraoperative gonioscopy is very important to use Swan-Jacob lens and this positioning.
So
like
this is very, very important. To
Yeah.
have an en-face view of the angle, we have to tilt the patient's head and tilt the microscope.
Yes.
So now what Sushma has done is she's tilted the patient's head, she's tilted the microscope, and
Helon,
now she's
please.
going to place the gonio lens over the cornea. So
So-
before that,
So I think it is important to emphasize that this is not at all difficult. I mean, when I did it for the first time, it was
Yeah.
not difficult at all. You just have to orient yourself. And if I could see the angle, I'm sure everybody else can see the angle because I am not a glaucoma person as
so
such.
this is the gonio lens which is provided by these eye-strained people only.
Okay.
It is called eye prism.
So
It
this-
has got very wide view. You can see the view is very wide compared to the previous bank procedure which I showed. That's what is secure flex by ocular. It was a hands-free lens. This comes with a handle. And now over to you, Sushma.
yes, so if the microscope screen is visible there, microscope view is
Now
visible.
it is better.
It is visible.
थोड़ा tilt और करना है. So,
Now it is visible.
can everybody see the angle there?
Yes, ma'am, we can see the angle very clearly.
So it is still not the end-face view. I would want little more tilt there.
Sure.
Yeah, it's okay.
Microscope you want?
Yes, little more. Bas, that's fine.
We are not focused, huh?
Yeah, we have to.
So now the angle structures are seen clearly.
Yes, yes.
Yes, so you have to look at the trabecular meshwork. Now, I need the injector, please.
So as Dr. Amita just said, this is has to be used with the handle, and the previous gonioscopy lens was hands-free.
Yeah,
Yeah,
so you have both the options available. So you can see the structures now, very nice open angle.
This
You can
lens
see
is,
the trabecular meshwork, scleral spur, the ciliary body band.
so when the manufacturer gives you to do it, does the lens also is given by the manufacturer? You have to have the possession of this lens, or you
No,
have
no,
to buy
we
it?
have to buy our own lenses. The manufacturer doesn't give the lens free of cost. If he wants,
Okay.
he will supply the lens. Now you can see she's got the accent inside.
Yes,
Yeah,
yes.
so now I'm retracting the the sleeve from the trocar
Right.
as I'm closer to it. So now you can see the head of the tip of the injector.
Right.
Yeah, so a slight dent, and I'm injecting.
Nice.
So you can see, hear a click sound once you inject.
And you,
Stay there, create a dimple.
yes. Do you also feel it tactically, the click when you do it?
Yeah,
Yes.
Yeah.
yeah. So you can see the stent is there. So if you want, you can just press it a bit more so that it remains stable. But this is nice, I think. Sushma, well done. Very nicely placed.
Very nice.
Very nicely done.
Superb.
So now we have to place the other one. 2 to 3 clock hours apart. The view is not great. I think I'm just
I think the
adjusting.
bubbles are probably coming in.
Yeah, can
Yeah,
you
better,
see now?
better, best.
Yes, yes.
Yes, we
can
can
see
see.
very clearly.
So this is the beauty with this eye prism lens because it's a wide view.
100%.
You can just go 2-3 clock hours and then see. You can see the nice dimple created, and sometimes there is a oozing from this stent. When you inject the stent, that means it's a good sign.
Yes.
So yes, you can see this stent. It is
Yes.
not
Yeah, both
inside
stents are
properly.
visible
She's
now.
trying to press it.
Yeah, so that was under implanted, the little one, first one, so I just pushed it in.
Right.
You can see the first one and this is the second one. Okay?
Very nice. I think we could really appreciate the view of this lens was much better than the previous lens for sure. And very nice demonstration, Dr. Sushma. Very, very beautifully demonstrated.
Beautifully done.
Thank you.
Absolutely.
Excellent, Dr. Sushma. Piyush here. So again, from somebody who's not a glaucoma person, a retina guy, so seeing this for the first time was very, very nice. So is both the stents, they came out through the same same trocar injector?
Yes, they are in the same injector, and what you have to keep in mind is once you press the injector button, till the time you remove your trocar, that means your stent is placed on the angle, you should be keeping it pressed. So come out with that, and once you see your stent, then you can release the button. And then the second stent is ready to be delivered. So either if the view is not comfortable, you can come out and adjust, put the more heel on and then do the second one. If the view is okay, you can just do how I did just now. Just go to the second side, 2 to 3 clock hours away, and then implant the second one.
Very nice. Thank you so much, Dr. Sushma, and beautiful demonstration. I think because of the want of time, we'll probably go to the next